Welcome to the Boise Business Podcast, Episode 6, where we interview local business leaders and get real-world feedback and their processes on how they run their businesses. I'm your host, Reese Phillips, and with me today is Nate Thompson, PA, with the St. Luke's Hospital Medicine Group. This episode is sponsored by Preferred Senior Benefits, where the seniors turn to understand their Medicare health insurance needs. Nathan, can you hear me?
Yes, I can.
How's it going today?
I am doing great. And yourself?
Well, you're making me look underdressed on my own show, so I do appreciate that.
Yeah, I was just, it's easier to be overdressed than underdressed when you don't know what you're going for, so I went with that. But sans tie, that was where I drew the line.
When I'm dealing with medical professionals, which I do all the time, you guys always tend to be very well dressed. So I appreciate that, and I think it's just built into your DNA as a medical professional. So I appreciate that. Well, thank you for being on the show. We're really excited to have you. Kind of give a real quick synopsis to the listeners. We're going to turn it over to you to give a real quick bio. Then from there, I'm going to turn to Nathan and ask him 5 specific questions so we could get his understanding and his knowledge and feedback about how he runs his business and how he works, as a healthcare professional in today's crazy world. And then we'll have a few follow-up questions for each one of those major questions. So with that being said, Nathan, I'll turn it over to you for a bio.
Thanks, Reese. So I am a physician assistant with St. Luke's Hospital Medicine. I am the lead advanced practice clinician for our group, meaning that I do a kind of mix of clinical responsibilities, bedside care of patients, but also participate in hiring, onboarding, training of PAs and nurse practitioners in hospital medicine for our group, and then also participate in quality improvement efforts at the group level and even at times at the hospital system level. So that's my primary clinical responsibilities. I'm also the president-elect for our professional organization, the Idaho Academy of Physician Assistants. So I have some responsibilities there as well. I'm a graduate of the Yale School of Medicine PA program, graduating in 2007, and I've been practicing full-time clinically with the addition of those mentioned administrative responsibilities since that time.
Wow, so that was a lot there. So did you say you went to school at Yale?
Correct.
Okay, so Nathan, that is not something I knew about you. That's very impressive. I'm going to have some off the podcast questions for you about that school because I've heard some very interesting things, but that's not here nor there. So with that being said, what made you choose Idaho?
So I grew up in Idaho Falls. Great place to grow up, and I've always loved Idaho. We're a multi-generational family here. My dad's side of the family had a farm in Downey Preston area. You may know Preston from Napoleon Dynamite, and
yes,
they've been there basically, I think, since late 1800s. So Idaho is where we grew up. Fishing, camping. Enjoying the outdoors, and enjoying just the quality of life we have in our great cities here as well. So I actually left Idaho for about 6 years to go to PA school at Yale, and I worked at Yale New Haven Hospital for about 4 years after graduation until I really got the right opportunity to come back to Idaho with the St. Luke's Hospital Medicine Group, where I've been since. I was asked, along with my wife, who's also a physician assistant, to essentially start the advanced practice clinician portion of our hospital medicine group and basically integrate PAs and nurse practitioners into the practice of hospital medicine for the St. Luke's, Boise, and Meridian campuses. So that was basically the right opportunity to bring us back. But really from the time I graduated, the intent was to make our way back to Idaho when the right moment occurred. And luckily, we were able to get that opportunity in June of 2011, have been here since and have been very happy.
Well, that's awesome. Anytime you can, leave where you grew up and want to come back, I think that talks volumes about how amazing Idaho is.
Absolutely.
And we're so glad that you guys made it back, you and your family. So that actually transitions to the first question I have for you. why did you make helping people your life's work?
Uh, First of all, love the question, because it actually really speaks to how I made this career transition into medicine. So it was kind of an interesting transition for me. A lot of people who go the PA or physician assistant route have actually come from another career first. Sometimes it's somewhere else in allied health first, and other times it's from entirely different careers. My background before going to PA school is I was doing essentially bench research in microbiology. I had completed a first degree at University of Idaho in philosophy, and was finishing a second degree in microbiology and working in essentially a microbiology lab where we were studying the antibiotic resistance mechanisms of Staphylococcus aureus, which is a bad bug, bad human pathogen that we deal with a lot in the medical field. And where the transition for me occurred was essentially bench research, although important, and there are, some people who that's the right calling for them, for lifelong work. For me, was a little bit too isolating, and I kind of found myself kind of drawn to the translational aspects of it. Where does it actually impact clinical medicine, and kind of more interested in my kind of colleagues, travails and working through issues with them than I was in kind of my own work. And after a couple of years of doing this and realizing that, the lack of human connection is probably going to be a challenge for you long term, I basically started researching, career options within the medical field. And I had actually done, as part of the microbiology curriculum, essentially all of the pre-medicine requisites to apply to, for example, medical school or PA school or other kind of allied health professions. It was just in the course of kind of doing research and also talking with a PA I knew who had basically made a similar career transition and was at that time working in medical oncology, that kind of led me to think this is the right transition for me. So basically, I spoke to, at the time, the professor I was working with, a brilliant guy named Ken Bales, who's now at University of Nebraska Medical Center, and said, I really think that where I belong is kind of at the bedside, translating the work of great basic scientists like yourself into medicine. And he said, if this is what you want to do, go for it. And he actually was one of the folks who wrote my letters of recommendation into PA school, and along with some other good mentors and guides at that early life stage, kind of put me on this path. So that's kind of how I got into this, was seeking kind of a greater level of human connection. And then basically, once I was into school and starting to do clinical rotations, what I found kind of the best fit for me was internal medicine, because those patient relationships that you get to forge in really adverse circumstances for those patients who, the day you're meeting them may well be the worst day of their life with the health issues that have brought them to the hospital. And so it really takes a special, I think, commitment to empathy and to forging those relationships with people who are really struggling and who may not actually be well positioned to, interact in maybe the most, friendly sort of way. To the credit of the people in our community, it's actually pretty incredible to see just how amazing people are in those challenging moments. And so we're actually very, very blessed with the community that we have, that even catching people when they're really sick, when they're really stressed, when they're really, fatigued, we still have the ability to have these, great interactions and great relationships, and really, be able to forge that connection that allows for really an optimal patient caregiver relationship. But nonetheless, I think it was something that was a unique challenge for me from the time I was a student to early career on. And it's something that I've never stopped loving in 12 and a half years now. And hopeful for many, many years of that to come. So I think that, the human connection was really the thing that brought me into this, in the medical field broadly. It's the thing that's kept me in internal medicine for the time that I've been in it. And it's the thing that kind of makes me excited to come to work every day, is getting to have those types of interactions. And, we get to help people on their worst day. We get to help them and see them get better before our eyes in the hospital setting, from, when they come in really sick to when they leave. And in some cases, what we end up doing is helping people, pass with dignity and comfort who otherwise would not have that same dignity and comfort. So it's a very heavy responsibility, but it's one that I feel very blessed to get to have that responsibility, and to have those types of connections and interactions with the people of our community every day.
That is awesome. And that, what I really took from what you said, and there was a lot of great information, and thank you for sharing that, is that ultimately it's about the connections and the relationships why you got into the medical field. Is that a good synopsis?
Yeah, it certainly is. I think, the thing that was interesting about doing bench research is there's a certain intellectual challenge to it. And that's, I think, an important part of a fulfilling, career, is that you're challenged by it intellectually, and that kind of discovery and building of your knowledge and expertise in an area is very important to long-term career satisfaction. Again, the very blessed position I think we have in medicine is that we get to experience that advancement in knowledge over time, building on the work of primary bench researchers and also clinical researchers, and getting to build that knowledge and expertise over time. But we also get to see it applied in real people's real lives, and see the benefits that derive from that research and that work, translating to people's ability to recover from illness. And so it's really a unique, and again, I'll say very blessed position to be able to get kind of that intellectual challenge and rigor, and all of the satisfaction that comes from building your knowledge and expertise over time, but also getting to apply it directly into people's real lives. You see the importance of that research and the benefit that accrues to your patients when you apply that research and knowledge correctly. And you get to have that kind of connection with them as, again, hopefully they are able to recover, improve, and move on with life if treated correctly. So there's a lot of fields that are intellectually challenging and interesting, but there are relatively few where you get to see in almost real time the benefits of that knowledge being applied to real human lives, and seeing those benefits in again almost immediate terms.
Yeah, I would agree. In my business, helping seniors with their healthcare insurance needs, you see that instantly because they just feel that relief. And my helping them is nowhere near the level that you guys do. So that's got to be super fulfilling. And that actually brings me to my next question for you, Nathan, is that, people think about getting into the medical field, whether it being a doctor, a PA, a nurse, a practitioner, whatever it is. And they hear about all the great things and all that stuff that comes into medicine. But what is one of the hardest parts about being in the medical field that no one talks about? That's my question number 2 for you.
Yeah, I don't know that this necessarily qualifies as something that nobody talks about, because I think there is certainly, I think, an increasing public awareness of the issues that we have with healthcare delivery, in the United States, kind of partial free market, medical care delivery system. But when essentially affordability and insurance sort of barriers to give an optimal care to patients crop up is not infrequent in healthcare kind of delivery. That can be really kind of challenging, and it's really disheartening to see a patient who for example, has started rationing their insulin because of affordability, and is now having really serious and potentially irreversible, adverse consequences of that. And that's, one example amongst many. So that's one of the things that's really challenging at times, and it can be something as simple as, time spent in medication prior authorizations that isn't really the most, fun part of the job, but it is necessary to get, the right medicine to the right patient at the right time in some cases. But just kind of affordability of healthcare broadly, and being able to give the right type of intervention to the right patient is important. And when you can't do it, when you hit a barrier that just you can't quite overcome, it's really kind of a disheartening sort of situation. One of the things I feel really very fortunate to work at St. Luke's specifically is the level of commitment from our board down to the bedside in terms of marshaling resources to kind of help patients with management of their health and overcoming barriers, whether they're affordability barriers or whether they are what we call in medicine social determinants of health. So things that aren't necessarily directly related to healthcare delivery, but things like the living environment, the access to transportation, the access to healthy food, et cetera. St. Luke's has really shown a commitment to community outreach and basically creating and developing programs that help overcome those barriers to optimal healthcare delivery, and really focusing on the health of the whole person, as opposed to, writing a prescription and putting it in their hand and saying, you're taken care of, go ahead and get better. That being said, I think there's a lot of work still to be done there. And really the stage I'm at in my career is, continuing to enjoy the bedside care delivery and clinically rounding at the bedside, but also starting to increasingly participate in those, efforts to improve affordability, improve patient access to healthcare, and also look at ways that we can help overcome those social determinants of health that ultimately impact people's health, more so than the medications we write prescriptions for, or the physical or occupational therapy interventions we, refer for, et cetera. Basically, broadly speaking, I think the challenge that we have that, depending on how plugged into healthcare policy you are, may or may not be aware of, is just that there's a lot more to optimizing the health of your patients than writing prescriptions or even creating what you think is an optimal plan of care. You really have to take a more patient-centered and holistic focus on the patient's entire circumstance, and then work through a number of barriers through there. And that's something that's, an important and exciting challenge, but it's also something that at times admittedly can be very frustrating, especially when you hit a wall, so to speak, that you just can't find a good solution to because it's outside essentially your sphere of control. So that's the big one that I would highlight. And I would also highlight that, it's an area that we are aware of and actively working to solve. And again, we have a great, commitment from our board level down to solving those problems, but it is certainly not solved. It is an ongoing area of challenge. And again, at times can be a very frustrating one when you can't get the right intervention to the right patient at the right time.
And do you see this as something that's going to get better with the new world that we live in and the way that we're doing things, or is going to be impacted negatively? Because, what you just said, or at least what I heard, was that it's frustrating to have to deal with some of the bureaucracy and the insurance side of it when you're treating your patients, and want to be able to give them a whole health plan that'll keep them healthy throughout the process, but there's a lot of roadblocks. So how's that going to be impacted?
Yeah, just a great question. So, the elephant in the room obviously is COVID-19 and its impact on healthcare delivery broadly, right? We've got clinics that are essentially closed or, telehealth visits only. So you've got access to care, potential barriers there. In parts of the country, you've got hospital systems that are overwhelmed. In other parts of the country, like here in Boise community, for example, you've got hospitals that are actually running low census because people are afraid to go to a hospital for what would normally be routine care of certain issues. Because they're afraid of getting sick. They're afraid of contracting a disease while there that was worse than the thing that brought them there.
Yeah.
And so that's been a unique challenge of the last 10 weeks here. I think that this crisis that we're all experiencing right now is, in the short term, it's unquestionably having negative impacts on people's lives and health. And in many cases, their economic situation as well, obviously. And that's going to continue, I think, for some additional weeks and months before the ship gets righted. However, I have seen some promising innovations that have occurred during this time. And I think that the development and progression of those innovations is ultimately going to have a positive impact on people's access to healthcare. That could have lasting benefit. So I'll give you an example, Reese. My wife, I mentioned, is also a physician assistant, and the work that she does is in pancreatic cancer screening. She and the surgical oncologist that she works with really provide a super specialized service to essentially almost the entire state of Idaho and about a third of the eastern portion of Oregon. So they have, under normal circumstances, patients coming from a huge geographic radius to be seen in a clinic visit that might last, 15 to maybe 30 minutes. With some of the willingness in the current situation to embrace telehealth that some of our payer sources have been willing to, be more flexible on than they were historically, they've been able to provide really the same level of service and counseling using telehealth services without, patients, in many cases, patients who may be somewhat, debilitated, having to make a 100-mile journey to
be able
a
to see the
physical
doctor.
clinic.
Yeah.
To be able to see somebody and having to find parking and negotiate the, busy downtown Boise, which, some of our rural patients find very challenging, especially if they're also elderly, right?
Yep.
And so it's really been a wonderful service for those patients. There are some things that are going to have to be provided in a physical space, like post-operative, care assessments, imaging, certain things like that can't necessarily be done in the home. But there's a subset of care that can be really very well delivered in the home, and actually maybe better delivered in the home than physically coming to a clinic, and all of the challenges that presents, and those challenges sometimes resulting in a patient not being able to get to an appointment on time, miss it, and then they can't get rescheduled, et cetera, in a timely fashion. So I think the telehealth model and basically this crisis driving adoption of that model is an innovation that is in the long term going to hugely benefit patients in terms of convenience, in terms of access, in terms particularly of patients who live in remote rural areas, having access to high quality specialist or even hyper specialist level of care without having to make an entire day of seeing a 15-minute appointment. The other innovation that's really just starting up at St. Luke's specifically has to do with COVID-19 itself. So I have a colleague, Dr. Adam Ballinger, who's really a brilliant physician, and I think also a brilliant mind for care delivery. He has been working with our telehealth group on a program that we call remote patient monitoring. And basically, if you read the news, you've heard stories of people who showed up in an emergency department. They tested positive for COVID-19, but they were considered, for whatever reason, lack of a supplemental oxygen requirement or relatively stable vital signs, to not be sick enough to require hospitalization at that time. And so they're discharged to home, and a subset of those patients get really sick at home, and some of them never make it back to the hospital. Really tragic story. Oh, yeah, absolutely. There's a really tragic story. Young man, I think right around my age, and healthy, who showed up in an emergency department, tested positive, vital signs looked good, went home from the hospital emergency department with a instruction to return if certain parameters occurred, and then he died in his sleep overnight.
Oh my God, that's horrible.
Yeah, really tragic story. And that's not a commonplace thing, but it is the case that with the silent hypoxia that we see in COVID-19, that somebody could actually get really sick in a short window of time and not make it back to a hospital. Conversely, though, hospitalizing everybody who tests positive is clearly not the right solution either, right? If
Absolutely.
they're otherwise hemodynamically stable, the economic impacts to those patients and the, increased risk of nosocomial spread, et cetera, is not the right answer. So what Dr. Ballinger has been kind of working on and has actually got up and running as of this week is a program called remote patient monitoring. And it basically leverages the technological advances that we've seen in telehealth, as well as some of the technology that we have available to actually assess objectively people's heart rates, oxygen saturations, blood pressures, temperatures in a home setting, along with a direct connection with scheduled check-in points and the ability to initiate unscheduled check-in points with a board-certified internist or even critical care physician if necessary from their own home. So they can basically get seen in a hospital emergency department, or they might have a more brief hospitalization just for assessment of initial clinical stability, return to their own home where they're obviously not incurring hospital level of expense in their care. It's a much more comfortable environment. They're not isolated from their families and caregivers. And they're being monitored in much the same way that we would do in a hospital for development of those more concerning symptoms or objective signs of deterioration, like progressive hypoxia, et cetera. And if they're cruising along doing great, we've got basically objective data that they're improving day over day. They can basically write out the entire course of illness in their own home. And if they are deteriorating, we actually have what we refer to kind of colloquially as boots on the ground, or essentially trained clinicians, usually PAs or nurse practitioners who are part of our home healthcare services, who can actually go to the patient's home, do an assessment in the home, and then make a determination as to whether bringing them in for hospitalization is the correct course of action at that juncture in their illness, or if they're okay to continue to remain in the home. So
that's really impressive.
Yeah, he's done amazing work on this front. The next kind of step in this that he and I are actually working on together right now, we're hopeful we'll be ready for prime time within a week or so, is actually leveraging some specialty sort of expertise in COVID-19 care specifically through telehospitalist, even for the patients who are in the hospital setting, where basically we'll have the technology in the patient room and we'll be able to remote in within minutes if they're having issues to either be seen, again, via the telehospitalist technology by a board-certified internist or by a critical care physician, and we can basically do those check-ins within minutes.
Wow.
My role in that as a hospitalist physician assistant is I'm going to be essentially the boots on the ground, quote unquote, equivalent of our home health folks. So I'll be physically in the hospital, and if a patient were to deteriorate, I can go to that bedside and see that patient immediately. I can basically have the telehospitalist physician, sort of directing sort of care with me in the room, able to do, certain interventions. And we also have the ability to, pull the physician or a partner physician into the room at any time. So that's kind of the next innovation that we're working on. And I know I'm kind of over time for this specific answer, but I'm giving specific examples of work that's ongoing and that we're trying to basically work through the logistical hurdles on the telehospitalist side right now. But ultimately, I think that care delivery as a consequence of this crisis is going to advance in innovative and I think ultimately beneficial to patients, ways ultimately beneficial to patients, whether from a convenience standpoint, whether from an access standpoint, whether from a cost or value standpoint, that are going to be beneficial in the long term. And I think that those changes were likely going to happen anyway, but I think this crisis is going to drive the adoption of basically leveraging technology to provide a better patient experience that is more patient-centered, that allows them to be in their own homes for certain types of care delivery, and that I think allows them to, in many cases, incur less cost for their care. And I think that, that's going to be, one potential legacy of this is that it accelerated the timeline for those innovations to be adopted, to be improved, and to be ultimately delivered to patients. So I think there is going to be a silver lining to this, even though that in no way, trivializes the severity of this crisis for, everyone in the community. It's not a trade-off that I would have chosen, but it is the reality that we're dealing with. It's the hand that we're dealt, and we can either make the best of it through, innovations to the benefit of patients, or we can, try and, cling to our old care delivery models that don't really work very well in this sort of situation, and fail. So I know which side I'd rather be on.
True. And I think you bring up, a good point about silver lining, because I think when we're faced with this as a society, we have to figure out how to work through it. And, you and the team at St. Luke's are amazing. And the work that you guys are doing, hats off to you, and we appreciate all that. Another silver lining is that because you do give such in-depth answers, big surprise from somebody who's a PA at the hospital, and we want to make sure that we're respectful of your time, we're actually going to jump to question number 5, because this is one that's, I think, is really important for people out there that are thinking about becoming a nurse, a PA, a doctor, things of that nature. And it's one that I always want to ask my guests on the show. And that is, what advice would you give to a person looking to get into the medical field in today's ever-changing business climate?
Yeah, great question. So I think the first advice that I would give is advice that I probably didn't follow myself when I got into the medical field, which is to really research all of the roles that are out there in the healthcare field. I think the two that people are very familiar with are physician and nurse, and those are two vital roles in our healthcare system. The healthcare system really cannot function without those two roles, two of the most essential. But that may not be the right fit for everybody. So the number of other roles that are out there that are also very, very important to function of our healthcare system. Myself as a physician assistant, nurse practitioners, I think, increasingly play a vital role in healthcare delivery, especially collaborative and teams-based models of healthcare delivery in the United States. I think that's one that people should certainly research before they make their choice. Dietitians, physical and occupational therapists, speech language pathologists, radiology technicians, EEG technicians, just to name a few. Respiratory therapy, I could keep going, but there is probably a best fit for people's level of interest, the work-life balance that they want to have, and essentially what is most interesting to them intellectually and most satisfying to them in the types of patient interactions that they get to have. And really researching out those different roles before making a final decision that may well be your lifelong career, I think is hugely important. That, if you have the opportunity to do so, really should entail some shadowing of clinicians and allied health folks in the field, and seeing what their day-to-day reality of care delivery is, and what their challenges and frustrations are as well, and just kind of getting a very clear picture of sort of what that job actually entails, as opposed to what you think it's going to be like in your mind. And so that would be my single biggest piece of advice is, number one, make yourself reasonably knowledgeable about all of the roles that are important in healthcare delivery in either a hospital system or a community practice. And then from there, try your best to educate yourself to what each of those roles entails. Shadow if you have that opportunity to do so, and then try and find the best fit for the essentially life that you want to have and the work that is going to be most fulfilling to you before you make that final choice. Because once you're into, year 6 of 7 to 8 years of medical, training to become a physician, or even, a few years into a career as a PA or nurse, you're pretty committed at that point. It's not to say that you can't make a career change at any point. I'm a big believer in lifelong learning and always kind of learning more through continuing education channels. But I think there is a certain level of commitment that it's going to get harder and harder the further you are into a career path. So the more research you can do up front, really the better. I would say that I personally probably didn't do enough research in that regard before getting into the career that I chose. But I was exceptionally fortunate to, I think, find the right fit more by luck than by diligence. And I've been, tremendously happy doing this work for the past 12 years. But, it could also have been the case that I, found the wrong fit and wasn't happy with it. And I would, still be fairly committed, and it would be a pretty big step to, shift careers at this point. So I would say, don't count on luck like I did. Definitely do your research and try and make the best choice up front before you commit to a course of training.
Well, I think those are words of wisdom, because a lot of people get into what I consider to be accidental careers. And if you're going to get into something that's going to take that much training and that much money and that much sacrifice, you probably want to figure it out ahead of time to the best of your ability. So to recap, Nathan, I wanted to thank you so much for being on the show today and really giving us some great examples of not only how relationships can drive what you decide to do for the rest of your life, but also highlighting the amazing things that St. Luke's and the team over there are doing daily to help us fight the situation that we're going through. And I really do appreciate you being on the show. I want to thank everybody for listening to the show today, and thank you for being on. Anything else you'd like to leave with the audience before we head out?
There's one thing I'd like to highlight, really just kind of a message to the community, and that's I've seen, Reese, some really tragic cases in the last month of folks who were afraid to go to a hospital for very legitimate reasons, and had a condition that under normal circumstances we would treat and discharge from the hospital at or near full recovery within a day or two. But because they waited for a prolonged period of time to get care, those conditions advanced to the point where they had a much more difficult hospital course, a lot more serious complications, and may be left with lifelong sequelae of those conditions. So what I'd like to, say directly to the community is, if you have a serious condition, if you have symptoms suggestive of a serious condition, be it, symptoms of a stroke, symptoms of a heart attack, symptoms of a serious, pain in your belly that's not going away, that's getting worse and worse. Our hospitals right now, we have really good processes in place to keep people safe from spread of nosocomial infection. We've got good patient cohorting practices in place. We've got really good supply of PPE at St. Luke's, and I have heard as well at St. Alphonsus as well. And we've got, policies in place that are going to really dramatically minimize the chance of spread of this infection within our hospital walls. Please don't ignore serious health conditions or symptoms because we're afraid of getting this disease. I know that fear is out there, and it's really legitimate, it's justified, but But please, if you have a serious healthcare condition that's not being managed, that you don't have access to clinic to manage, or maybe it's just a more emergent sort of thing, please come in the hospital. We can still keep our patients safe from spread of infection. We can treat them and get them out of the hospital quickly, back to their own home if we can intervene early. But if we wait until it's really advanced or has started to cause ancillary complications, our ability to get the best possible outcome for those patients, diminishes with every passing day, or in some cases, with every passing hour. So I really want to emphasize the community. Please still come to the emergency department, come to the hospital if you have a serious health condition that you need care for. And we're very committed to keeping people safe and using all the appropriate protective equipment, room cohorting practices, and we have good policies in place to keep people safe from nosocomial spread of this illness. And we can treat your medical issue and get you home safely without engendering serious complications of a later hospital presentation.
Wow. Well, Nathan, thank you for that. I think that is a great point, and people really should be taking their health seriously. And thank you so much for sharing that. Want to wrap up today's episode by once again thanking Nathan for being on. So this was the Boise Business Podcast, episode 6, where we interviewed, a local business leader in Nathan, and he gave us his feedback and his processes on how he runs his doctor business, or PA business, excuse me. And thank you so much for being on with us. We really do appreciate it. And thank you so much for St. Luke's for, allowing this process to happen. It's one of my favorite hospitals in town, and I'm glad we were able to have you on. So with that being said, thank you all for your time. Thank you for listening to episode 6, and have a great day. See you later.
Thanks, Reese. Appreciate it.